I'm going to be your nurse today. Today we're going to do a physical assessment. At any time, if you feel uncomfortable, you just let me know and we'll stop the assessment. And also, I'm going to kind of talk you through some of the different body parts and things that are going on as I'm working through the assessment. Does that sound good? Okay. Now I'm going to start with the lymphatics. And what I'm going to do is locate the different lymph nodes in the body system. We're going to start by using the pads of my fingers. And I'm going to do the pre-auricular, which is in front of the trachea of the ear. And then I'm going to move to the post-auricular, which is behind the ear. And then we have the facial, which is in this region. Just using the pads of my fingers. And what would apply to one side of the body would also apply to the other. So I would actually be doing both here, but for all times and contents purposes, I'm going to do one side. Now we have the submental, kind of below the chin in the mandibular region. And then we have the submandibular, which is a little below that, more posteriorly. After that, I'm going to assess my deep cervical lymph nodes, and I would do that by actually hooking, using my fingers to hook, and I would inform the patient that this could potentially be just a little painful, but I'm going to do it as gently as possible. Could you turn for me? Notice the sternocleidomastoid muscle, and I'm actually going to assess the cervical lymph nodes in front, which would be my anterior cervical, and I'm just going to kind of gently hook, and then the posterior by gently hooking as well. And I would also want to assess the supraclavicular, which would be in between the clavicular or the clavicles, right in this region. And the last one is the tonsillar, and it's just below the angle of the mandible, so I'd say kind of right in this area. And as I'm doing this, I would assess for any edema or any warmth, any mobile lymph nodes. Are they edematous? Are they movable? Now we're moving along to the lymph nodes of the arm. And the first lymph node that I'm going to assess is the epitrochlear, which is posterior to the humerus in the inner elbow region, right in here. Now we do the same on both sides. And then I'm going to assess the axillary, which is under the armpit. So if you could lift your arm for me, assess right in here. And I would ask the patient if it's enlarged if they've recently had a vaccination, as this could be a normal finding. And next I'm going to assess the popliteal lymph node, which is in the back of the knee region. And you can't always feel this one. It's just occasionally palpated. If you would you lay down for me, Ashley? I'm going to assess your legs. And the lymph node, actually, I need you to abduct your leg, kind of lay it flat for me. The lymph node that I'm looking for now is going to be the superficial inguinal, and it's in this crease in the leg, right in this region. And then the inferior inguinal, which is in the femoral region, right in here. And it's in the lateral leg, so right here. And that's all for the arms and legs. Now let's move along to describing the lymph nodes. The lymph nodes that I've palpated, normally if I can feel them, they need to be soft. If they're firm, it can indicate a problem. But not all lymph nodes that are palpable indicate a problem. The lymph nodes of the head and neck, if they're palpable and less than 1 centimeter, it's often normal in an adult. Inguinal in the legs, if those are palpated and they're less than 2 centimeters, that can also be normal as well. You want to note if the lymph node is edematous. Is it swollen? That can be indicative of bacterial, viral infection, and that's known as lymphedema. Is it movable? Generally, lymph nodes are a little movable. If they're immovable, that could indicate a problem. Are there irregular borders? Generally, lymph nodes are very symmetrical. Does the lymph node move in a unit? And that's called matted. If it's like a chain, a cervical chain of lymph nodes that move together as one, that would be matted lymph nodes. Is the node shoddy? Does it feel like a BB actually under the skin when you take 2 fingers and kind of palpate around it? Does the node pulsate? And ask yourself when you're assessing the patient, If it pulsates, perhaps it is a blood vessel, an artery. Do you need to take your stethoscope and auscultate the actual vessel, if or lymph node in question? And if it is, then it probably is a blood vessel. Is it tender to touch? Lymph nodes that are tender to touch, edematous and warm, typically indicate a bacterial infection. And also ask yourself what nodes are involved. Nodes are more enlarged distally to the problem area. For instance, if you have drainage from an ear infection, perhaps these nodes in the submandibular region would actually be enlarged, indicating that it's actually more anterior. The problem is more anterior to the distal lymph node. Now I'm going to begin my assessment of the ear. And when I'm looking at the outer ear, I'm going to assess the external auditory canal, and I'm going to look at the cartilage-covered portion of the skin. And I'm also going to note the pinna, or the auricle, which is the top portion of the ear. And the pinna in most adults is about level, if you take an imaginary line from the outer canthus to the top of the pinna, it should be level with that. If it's less than that and there's also a slant, it could indicate a chromosomal abnormality such as Down syndrome. I would want to look at the color of it. Is the color of this actual external ear the same color as the face and the neck? If not, it could indicate perfusion problems. I would also want to palpate the auricles for any nodules, masses, or lesions. And I would do the same with the mastoid around it. And I'm not noting any right now. I also want to look at the landmarks of the ear. If Miss Ashley will come a little closer. And this top part is actually the helix, so I'm going to note that. The tragus right here, the antitragus just opposite of the tragus, the lobe, which, Miss Ashley has pierced right here. And then I would want to look at the concha, which is the opposite of the external canal. So it would be right in here, and I can actually place my finger in it. And those are the landmarks of the external ear. Now I'm going to inspect the auditory canal with an otoscope. This is my otoscope. This piece would actually snap onto the otoscope, but it doesn't work right now, so we're going to pretend. In the adult, the auricle should be pulled up and back. And since I'm visualizing the left ear, I would place the otoscope in my left hand. And half an inch of the speculum of the otoscope, which is the end piece, should be entered into the ear canal. More than that could actually damage the ear. So we're pretending I'm placing it in. And I'm going to inspect the tympanic membrane. And normally the tympanic membrane should be pearly white in color. If it's red, it could be indicative of otitis media or an external otitis infection. If it has any serous fluid or it's bulging, perhaps there's otitis media with effusion on top. I would also want to see if it's just a dark hole, and a dark hole could indicate proliferation of the eardrum or perforation of the eardrum. And I want to look for any discharge. Any discharge would not be normal, and it could also indicate an infection. As I'm assessing the internal ear canal, I want to note little hairs, which are normal, and some cerumen, which is earwax, and that's a little normal too. Let's see. And I'd also like to look further down, and you can actually visualize the bones of the ear. I would want to look at the umbo. I would want to note the malleus of the ear, the short process of the malleus, and a cone of light, which is underneath the umbo. It actually reflects. There's a light reflection there. I also want to look for foreign bodies in my ear canal as I'm assessing the patient, especially in children. You want to look for the foreign bodies as they're prone to, sticking things in their ears. And as I'm looking at the membrane, I want to note two more structures, and that's going to be the pars flaccida, and that's actually going to be the more flaccid, thin part of the tympanic membrane. And then we have the pars tensa, which is the thicker part of the membrane, and I want to make sure that they're attached in the ear. Now I'm going to be doing a series of hearing tests, and the first one I'd like to do is called the Rene test, and it's using a tuning fork. For this test, I'm actually going to test air conduction versus bone conduction. Air conduction should normally be heard twice as long as bone conduction. And what I'm going to do is I'm going to tap this on my arm, and when I'm going to put the tuning fork right here, and I want you to hold up a finger when you can no longer hear it anymore. I'm going to time those intervals, and then we're going to do the same in front of your ear, okay? And the findings are normal. The sound in front of her ear was twice as long as the sound on her mastoid bone. Now I'm going to do my second test, which is known as the Weber's test. And what I'm going to do is I'm going to still use my tuning fork, and only touching this base of the tuning fork, I'm going to place this midline on her skull after I've tapped it and it's vibrating. And I'm going to assess whether the patient can hear equally sounds in both ears. You're able to hear that equally in both ears? Mm-hmm. Okay. So this is a normal finding. If my patient wasn't able to hear it equally in both ears, I would repeat the test and I would occlude one ear, and the patient should actually be able to hear it best in the occluded ear. My next test, I'm going to do a whisper test, and for that test, it's exactly what it sounds like. I'm going to actually whisper something to the patient, a series of 3 numbers and letters, and I'm going to see if my patient can repeat that back to me. It is important to exhale before you do your series of numbers and letters, and I want to be standing about 1 to 2 feet away from my patient, so you're actually not going to see me in this video, but I'm going to step back and repeat the actual letters and number sequence. Okay, and tell me when you're ready, Ashley. Okay. 3T9. 3T9. Okay, and that was exactly what I repeated to my patient. 3T9 was the series of numbers and letters, and this is a normal finding. Now we're moving along to the external examination of the eye, and I'm looking at Ashley's eyes, and I'm going to assess the eyebrows to notice the distribution of hair, to make sure it's growing properly, and as I can see, her eyebrows are just fine. I'm going to assess the periorbital region, which is actually around her eyes itself, and I'm going to note any edema. Any edema that she would have periorbitally would be abnormal, and it could indicate thyroid disease. And I would also look to see if there are any yellow spots in the periorbital region, which could indicate a lipid metabolism problem. Also, I want to do an eyelid assessment. Would you open and close your eyes for me? Okay. And I'm noting her eyelids as I'm looking, and I want to make sure that they're closing appropriately and opening widely. And I also want to observe for flakiness, any edema, redness just on the eyelid margin itself. Are eyelashes present? Is there any drainage present? And I'm seeing that there's no drainage present. Is there ptosis? Is there actually drooping of the eyelid itself? And I see that her eyelids are completely normal. Is there entropin? Does the eyelid go inward, or does it fall too far outward, which is extropin? And then I'm going to move along to the movement of the eyes. And her eye itself is sitting appropriately. It's not moving repetitively, frequently, and rapidly, which would be known as nystagmus. And I don't see that she's focusing on objects simultaneously. Look over here for me, and right over here. So she doesn't have strabismus. Now I would assess Perla, and for that I would use a pen light, but I'm going to use this ophthalmoscope and just shine the light to see if it accommodates for light being shined into her eyes. And the pupil itself should actually constrict when it's when light is shown into the eye itself. Are the pupils round? Yes, they're both round. And okay, is it reactive to light? And they both constricted. So I would say that both pupils accommodate appropriately when light is shined into the eyes. And I want to assess the tearing gland, the lacrimal gland, which would be right around in here. And I would have on gloves for this assessment. And I would assess the puncta of the eye, which is actually in the corner of the eye. and that's actually the tear duct itself. Note any drainage or anything like that would be present. And that's all for my external examination of the eye. Now I'm going to assess the conjunctiva, and I'm going to actually wear gloves for this examination. And what I'm going to do is gently pull down the lower lid itself, and I'm going to note the color of the conjunctiva right through here. And I want it to be pink, but not pale, as that would indicate anemia. I'm going to check the other side. If it was too red, it could indicate infection. But also note if there's any pterygium present, which is a growth from the conjunctiva upward, and it's white and elastic in color, and I don't know if there's any here. Now we're moving along to the ophthalmoscope exam, and this is my ophthalmoscope. And to do this exam, pupil dilation is very important in this exam, so I would actually dim the lights or turn them off. And I wouldn't want to shine this right into the patient's eye. I would actually want to be to the side about a foot away. And since I want to look into the right eye, I'm going to place this in my right hand, and I'm going to use this hand to stabilize on the shoulder so I can get a good look in the patient's eye. And I'm going to have her focus on an object kind of far away. And first I want to assess the lens clarity. And the lens should be clear. A cloudy lens could indicate cataracts. It should be clear and rounded though, ideally. And then I want to assess the red reflection. And it's a reflection that illuminates the retina. And it should be, let's see, I should actually be able to see it through the scope. It's hard to visualize right now because the lights actually aren't dim, but we don't have a way to dim the lights in this room. And when I find the red reflex, I want to follow it into the eye and actually note the color of the retina. The retina should be red, orange in color. And if I don't see it, then that could indicate actually that there's a problem. So if I don't see the red reflection, there could be a retinal detachment. Now I'm going to look at the blood vessel characteristics in the eye. And actually what I'm going to do is I'm going to visualize them all and follow how the blood vessels branch. And I should note that arteries in the eye are going to be a little brighter red than the actual veins. And they should be smooth with no nicking. And I also want to note the disc characteristics. So I would visualize the optic disc. On the left eye, it would be located nasally at about 9 o'clock, and on the right eye, it'd be at about 3 o'clock. Okay. And the disc itself shouldn't have any cupping. The margins should be sharp and well defined, and it should also be creamy pink in color. So I would note those things as I'm looking at the optic disc. I also want to assess the physiologic cup characteristics, which is the brighter area of the disc. So I want to go back and look nasally at about 3 o'clock. And note that it's there and present. And then I want to look at the macula characteristics, which is the darker pigment in the eye, and no other color should be present. And it's about 2 diameters from the disc. And that concludes my ophthalmoscope exam. Next, I'm going to assess the muscles of the eye. And first, we're going to do the 6 cardinal fields of gaze. And to do that, I would actually have the patient follow my finger diagonally and up and down. So I'm going to do that. Okay. Follow my finger. And this tests for nystagmus, which is absent in my patient. And after that, we're going to do the cover-uncover test. And I'm going to tell my patient to stare straight ahead and focus on a near object, if you could do that for me. And I'm going to cover one eye. And have the patient still focus on that object. So we're going to cover this eye. And cover it. And we're going to do the same to this eye. Still focus on the object. And I'm not noticing that there's deviation from the midline of the object that's being focused on. If If she were to fixate on the object after the good eye was covered to accommodate, then that would indicate strabismus. Next, I would assess the corneal light reflection, and I would use a pen light or an ophthalmoscope. And there's not room to do it from 2 feet away, but I would actually be 2 feet away from my patient. And immediately, I would shine the light into the patient's eye, and this light should be, the reflection of it should be in the same spot in each pupil, which indicates symmetry, and if the test is negative, that's normal. And I see it in the same point in the pupils, so that's a normal test. Now I'm going to assess the corneal reflex in my patient, and I'm actually going to put on gloves for this test. And for this test, I'm going to use a cotton whisk, and I'm going to actually take some of the cotton from the end of a Q-tip, kind of leave it hanging out just a little. And I'm going to place the tip near the patient's eye and to see if the patient actually blinks. I'm not going to stick it in the patient's eye. Blinking is a sign of good corneal reflex as long as it's not absent or delayed. And my patient blinks. And I would do the same on this eye. And she blinks. Throughout the entire assessment of the eye, I'm going to be noting the sclera of the eye, which is the actual eye, the whites of the eyes. And I'm going to note the color of the sclera. If it's yellow or off-white, I might think of jaundice or a liver impairment. If it's pale, I might think of anemia. And if the sclera is reddened or pink, I would think allergies or infection. Now is the assessment of the chest and the lungs, and I'm going to inspect and palpate. And to inspect the lateral and posterior portion of the chest and lungs, I would have the patient sit with the arms across the chest to inspect the lateral aspect as well as the posterior aspect of the chest and lungs, and I'm going to note the shape, the symmetry, and the color front and back. And ideally, the patient would not have on a shirt for this assessment. To assess the anterior chest and lung, I would have the patient lay down supine. And I'm looking anteriorly with the arms away from the chest so I can actually visualize the chest wall movement, and also look at the color, the symmetry, and the shape of the chest and lungs. Sit up now. I'm going to note the respirations. I would not tell the patient that I'm assessing respirations. I would probably try to get a pulse and focus in on that, but actually be looking at the respirations. And I would do that for a minute, noting the respirations. Normal respirations are normally 12 to 20. I would notice if the respirations are bilaterally symmetric in the chest and if they're unlabored. Some clues that could suggest pulmonary or cardiac difficulty would be pursed lip breathing, retractions. That means breathing from suprasternal retractions would be up top, or diaphragmatic retractions down low, and it could indicate cardiac or pulmonary difficulty. I would look for cyanosis, central or peripherally, and flaring of nostrils, as that also suggests pulmonary or cardiac difficulty. Okay. As the patient breathes, I would also want to note patterns of respiration, whether they come thoracically, diaphragmatically here at the diaphragm, or if they're abdominal breathers. Next, I would look at the thoracic shape. I would note any barrel chesting, as seen in chronic asthma or emphysema or cystic fibrosis. And I would note any tenderness, any pulsations, bulges, depressions. And I would also want to assess my anatomical landmarks, would be the trachea, excuse me. I would also want to do the costal vertebral angle, right here at the ribs, and the angle of Louis, which would be about where the sternum is, and my C7 and T1. Now I'm moving along to percussion and auscultation of the chest and lungs, and I want to auscultate my patient before I percuss. And in order to do that, I would actually take my stethoscope and I would listen to the breath sounds. Take a deep breath. auscultating the lungs, I want to notice breath sounds in the tracheal region, in the bronchial region, in the bronchovestibular region, which is actually where it branches out to the bronchioles, and vestibular breath sounds, which are heard best where the actual lungs are located. I want to note any adventitious breath sounds such as crackles, which kind of sound fine, and they can either sound fine or coarse. Rhonchi, which is a deeper rumbling sound. Wheezes, which kind of sound like the obstructions heard in narrowed airways with asthma. And then a friction rub, which can be heard, it's like a dry grating sound that can be heard on expiration or inspiration. And it's heard with pericarditis. If it's pericarditis related, it's heard best. It can be heard when you're inspiring, but when you expire, it should stop. And if it's cardiac related, it will not. Next, I'm going to move along to my percussion, and I'm going to have you turn around for me. I'm going to place my hand on the patient, and the patient normally wouldn't have on a shirt for this assessment, and I'm actually going to tap this is my non-dominant hand, with my dominant hand, the interphalangeal joint of my middle finger, and there's a dull sound heard. It can be heard over a muscle. This is the trapezius muscle, so that would be your flat or dull sound. I'll also note over the liver, there should be a dull sound as well. I could also do this over the lungs. A normal lung would sound more resonant, which is not quite as loud. It's not quite as loud as hyperresonance. Hyperresonance would be heard with emphysema. Tympany is your loudest tone, and it can be heard if there's an air bubble present in the gastric region. I would also want to look at diaphragmatic excursion and note that. To assess vocal resonance, I'm going to auscultate while my patient recites numbers and letters and compare. Usually muffled and distinct are heard best meatily. And then we'll do a whispered pectoriliquity test, which is the whispered voice, and it should be heard clearly and intelligibly. So I'm just going to have you recite some letters and numbers. Recite the letter 1, 1. Now say 1, 3, 4, 1, 3, 4. And do the same. 1, 3, 4. Now whisper those numbers for me. If there's intensity of the spoken, or if there's intensity of the spoken words, or there's nasal quality to it, it can indicate lung consolidation. But if you can hear it and it's not extreme, then it's normal finding. Next, we're going to talk about cardiac MPV. And first, I want to inspect and palpate the heart. And I'm going to do this with my patient sitting. I want to do it with my patient leaning forward and supine. But for the video purposes, I'm going to do it with my patient sitting. I want to check the precordium, which is the area above the heart, for any thrusts, heaves, or lifts, as this could be abnormal. And then next, I want to assess the point of maximal impulse, which is at the 5th intercostal space, mid-clavicular line. So right in here. And I want to note the intensity of that region, and I want to note the duration of the amplitude. And it is bounding, and it's heard the loudest there. Next, I'm going to palpate and auscultate the arteries, and I'm going to locate my palpable pulses. First, I'm going to locate my temporal pulses, and then I'm going to locate my carotid pulses, but I don't want to check my carotid pulses at the same time, because this could cause your patient to, it could occlude the carotids. What I would do on one side, I would do on the other. Next will be the brachial, radial, ulnar, femoral, popliteal behind the knee, tibial, and then in between the great toe and the toe beside it, you should feel the dorsal pedal pulses. And if you ever can't feel your pulses, you would need to Doppler your patient, especially in lower extremities, as that could indicate that there's insufficiency to those extremities. It could indicate a clot or otherwise. And I'd also want to check my patient for Homan sign, which checks for DVTs. And how I would do that is I would have my patient lay supine. And I'm actually going to press the bottom of the foot upward. Tell me if it hurts any. You feeling pain? No. A positive Homan sign would indicate that there is pain in the calf muscle when the leg is flexed upwards, and that could indicate that there is a possible DVT, but this was negative, and in that case, it's normal. I want to also assess the edema of my patient. And look for any total body edema, anasarca. That's seen a lot of times with your CABG patients. So also when you're assessing your patient, like know your patient, and anasarca could be normal in a patient post-CABG because they're going to be that swollen. If not, then think congestive heart failure, fluid overload. There's an underlying problem there. I'm going to assess all areas, especially the areas that sit in a dependent position, such as like the hands for pitting edema, and the legs and feet, as a lot of times, fluid will drain in those areas as well. And I want to note whether it's trace edema, meaning just a little bit. Is it +1, +2, or +3 edema? And you just go up, as the edema seems to be worse. Notice if it's pitting or non-pitting. Pitting means that when you actually touch the skin, it will actually indent and rise back up again. And non-pitting means that, it's just really tight. I want to note the capillary refill in my patient, and I would want to do it on the hands and the feet. And you do this by pressing down on one of the fingers and noting when the coloration returns to the fingertips and the toes. And you want that to generally be less than 3 seconds. Any longer than that could indicate, peripheral vascular disease or underlying peripheral vascular disease. I'd also want to auscultate bruits, which can be heard over the temporal arteries as well as the carotid, and it's caused by the turbulence of the actual blood flow through those regions. And for video purposes, I'm just going to do the temporal, and I could hear the bruit. Next, I'm going to auscultate the heart. And I'm going to note the rate, rhythm, and intensity of heart sounds and any splitting of heart sounds. In general, the heart should sound like a love dub, but any sounds that sound, for instance, like a Kentucky in the heartbeat, that additional sound could be a gallop, or it could indicate that S3 could indicate, it could be an innocent murmur, or it could indicate congestive heart failure. It could be an early sign of that. I would want to assess the aortic, pulmonic, Erb's point, tricuspid, and mitral valve. Aortic is heard at the second intercostal space, right sternal border. So intercostal meaning in between the second rib. Pulmonic on the left side, second intercostal space. Erb's point on the third side, intercostal space, left sternal border. Tricuspid right under that at the fourth intercostal space. And mitral, which is the apical pulse, and that's where it's heard the loudest, is at the fifth intercostal space, mid-clavicular line. And in a lot of women, you'll have to actually lift up the breast to, get under there and hear that point. So I'm going to assess those valves in my patient now. And that's all for auscultation of the heart. I want to assess my patient for jugular venous distension, and I would have my patient turn to the side for me. And I'm noting the actual jugular, and if there's any distension, it will stick out greater than 30 to 45 degrees, and you can also feel it, and I'm not noting any distension. Let me get you to turn to the other side. no distension present. If there is any distension, it could be indicative of underlying cardiovascular disease. I would also assess my patient for venous insufficiency by looking at lower extremities, and I would look at the extremities in her legs and note whether they were cool, non-pink, or colorless, and that would indicate to me venous insufficiency. Normally, you want all of your dependent extremities to have color, and that indicates that they're getting really good perfusion. And you also want to check those extremities for pulses present to make sure that there is adequate blood flow to those areas. Throughout the whole portion of your head-to-toe assessment, you should be assessing the mental status of your patient as it falls under the neurological boundaries. You want to look at your patient for appearance and behavior throughout your entire interview when you're asking them, their history. And what you want to really look at is, are they dressed appropriately for the season? Are they acting appropriately to the situation? You also want to assess the cognitive abilities of your patient. So at the beginning of the assessment, I would probably ask your patient to repeat, to actually remember 3 different numbers or 3 different words, and to repeat them back to you at some point during the assessment. So at this point, I'm going to ask you to remember the following words: run, jump, play. Okay? And I'll ask you to repeat those back to me later. You also want to assess judgment in your patient at some point during your assessment. So I'm going to use the statement, the early bird catches the worm. What does that statement mean to you?
It means if you get up early, you get more done.
Okay, and that makes sense to me. So I can tell that her judgment is intact. And also assess your patient for an altered level of consciousness. And you can tell this throughout the entire interview with your patient. Do they seem alert and oriented to person, place, time, or do they seem out of it? Do they seem lethargic? Obviously, lethargy is not going to be normal in your assessment, so it would warrant more investigation. Now I'm going to assess the cranial nerves, and the first nerve that I want to assess is cranial nerve 1, which is the sense of smell. And to assess this, I would probably have, a lot of times you'll have coffee in an office, and I would actually put the coffee grounds in a filter and put it up to the patient and see if they could actually smell it with their eyes closed. And if they can smell, then of course olfactory is intact, and that would be cranial nerve 1. I would also do cranial nerve 2, which tests visual acuity and visual fields. And for that, I would use a Snellen chart, which is the actual chart with the different size E's and the different letters, and see what they can see from 20 feet away. And after that, I would assess the extraocular muscles, which I've also done in the portion of my eye exam. That would tell me if the cranial nerves 3, 4, and 6 were intact. And in order to do that, I would do the 6 cardinal fields of gaze. So if you will, let me stand in front of you. I'm going to have you follow my finger in 6 different directions. And she did that with no problem. And also I will do the cover and uncover test as seen earlier in the video. Moving along now to cranial nerve number 5. I'm going to look at the symmetry of the face, and I would probably palpate the jaw muscles. Open and close your mouth for me. Okay. And I'm noting symmetry of the jaw muscles. And I'm also going to assess with cranial nerve 5 the corneal reflex, and I did that earlier in the video, but I'll show you the supplies that are needed. I would actually need my gloves, and I would need the Q-tip, and I'd pull the whisk of the Q-tip, and I'll pull that out and actually touch it to her eyelashes and, get it as close as I can to see if she blinks. If she in fact blinks, then that's suggestive of normal findings. If it is absent or delayed, then there could be a problem with cranial nerve 5. Throughout the assessment of the cranial nerves, I want to notice the symmetry of the face and note any drooping of the mouth. One thing that you'll see drooping of the mouth with is with cerebral palsy, and a lot of times that will happen if there's damage to cranial nerve 7. I'm going to ask my patient to do a few things to assess cranial nerve 7, and I want you to raise your eyebrows. Okay, you can put them down. And she was able to do that. Shut your eyes. Okay, very good. Wrinkle your forehead. Okay. And I want you to smile for me. And I'm assessing the smile to make sure there's no drooping. I want you to frown. Okay. I want you to show your teeth. Okay. I want you to puff your cheeks out. And another way that you can assess cranial nerve 7 is to give them something sweet and give them something salty. And the salty is actually cranial nerve 7, and sweet, which would be the anterior 2/3 of the tongue that you're actually assessing. With cranial nerve 8, I would do the whisper, the Weber test, and the Rhine test for hearing, and the Romberg test for vestibular function. The Romberg test will be in musculoskeletal, and the whisper, Weber, and Rhine tests were already seen in the ear section. Now, moving along to the gag reflex. I'm not going to actually do this, but I'll tell you what you would do. You would have a tongue depressor, such as this one here. And with the tongue depressor, you're going to actually, press it down in the patient's mouth and then kind of stick it back just a bit and to actually see if they gag. And that is a present gag reflex, and that's normal. If it's absent, a swallowing study could be needed. It could indicate that your patient maybe had a stroke, they're having some problems swallowing. You certainly want to investigate that. 10, cranial nerve 10 it's the same basically essentially as 9. It's the gag reflex and swallowing ability. So you're going to again do your tongue depressor test for gag reflex, and you're also going to tell your patient to swallow. And you should visibly be able to see swallowing. Cranial nerve 11, movement of the trapezius muscle. You're just going to have your patient shrug your shoulders. If you would, just shrug your shoulders for me. Okay. And cranial nerve 12 is tongue, is actually just the tongue itself. I want you to stick out your tongue for me. All right. And note the symmetry of the tongue, the position of the tongue, and the movement of the tongue. Just kind of move your tongue all around if you can. Very well. And also note lingual sounds made by the tongue, such as your L, T, D, and W. And that's when the tongue actually goes from the bottom palate to the upper portion of your mouth. L, T, D, W. Okay. And she was able to do that with ease. That concludes the cranial nerve assessment. Now that we've finished the assessment of the cranial nerves, I'm going to ask you to repeat the 3 words that I asked you to remember earlier. Can you repeat those for me?
Run, jump, and play.
Okay, and she was able to repeat those, so her cognitive abilities are intact. Now I'm going to assess sensory function in my patient, and I'm going to do that by assessing primary and cortical sensory. First, I'm going to start with primary sensory, and I'm going to assess touch in my patient. I'm going to put some gloves on. And I'm going to have my patient take off their shoes and socks. And using a cotton wisp, you can lay back for me if you like. I'm going to take the patient's foot, and I'm actually going to touch the bottom of the foot with the cotton wisp. Did you feel that? Mm-hmm. Okay, I'm going to do it on the same side. Were you able to feel that? Mm-hmm. Now I'm going to assess superficial pain, and what I'm going to do is touch the patient in an unpredictable pattern, and I'm going to touch with a sharp and smooth side of an instrument, and for this I'm going to use a tongue blade, and I'm going to have the patient point to the area touched. Okay, this would be my rough side, and this is my smooth side. And what 2 places did I touch you? There and there. Okay. And I would do the same on her lower extremities and just in various different locations of her body. And I would move along to temperature and deep pressure if she didn't have a normal finding in the area of superficial pain. But in order to assess temperature and deep pressure, I would, for temperature, I would get 2 test tubes, and I would fill one with hot water and one with cold water, and I would roll them against her skin to see if she could tell me, oh, that's cold water if it was the cold tube, and it's hot water if it was the warm tube. And deep pressure, I would actually assess in the trapezius muscle or the biceps. And what I would do is actually squeeze and see if she could feel it. And that's how I would assess the deep pressure. Vibration, I'm gonna have you lay back for me. I'm gonna actually do this on various locations. One of the locations I'm gonna do with my tuning fork is the bottom aspect of her foot. So I'm gonna tap this, touching only the stem. I'm gonna place it on the bottom of her foot. Are you able to feel that?
Mm-hmm.
Okay, and you wanna do it over more of the bony prominences. Okay. Able to feel that?
Mm-hmm.
You can rise up. And now I'm going to assess joint position, and I would do that in various joints, but for video purposes, I'm just going to do one. And I'm going to do the joints of her fingers, and I'm going to touch the lateral aspect of the joint, and I'm just going to move it up and down. Are you able to feel that?
Mm-hmm.
Okay, now I'm going to assess cortical sensory with my patient, and stereogenosis is going to be assessed by handing the patient a familiar object and seeing if they can identify by touch with eyes closed. Can you close your eyes for me? Okay, I want you to touch this object and tell me what it is.
Cell phone.
Okay, and she was able to identify that that was a cell phone with ease. Now we're going to move on to 2-point discrimination, and I'm going to alternate between one and both points simultaneously, actually touching the patient, and I'm going to find the distance to which the patient can feel those points, and normally it should be anywhere between 2 to 75 millimeters, and that's normal. Can you feel those 2 points? Just tell me when you can feel a point. And graphesthesia is another assessment that I want to make with my patient. So I'm going to have her put her palms out and eyes closed. And I'm actually going to draw a letter in her palms and see if she can tell me what letter I'm drawing in each of her palms. What letter was that? A.
P.
Okay. And now we're going to move along to point location, and you're going to touch the patient on their skin, and you're going to have the patient point to where they were touched. So close your eyes for me. Okay, and you would just do that all over to kind of assess the cortical sensory in those areas. And that's all for sensory function. The next section I want to focus on is coordination and fine motor. And what I'm going to have my patient do is I want you to pat your knees, and I want you to alternate having your palms up and down. And when I tell you to gradually increase the rate, gradually increase hitting your knees. Are you ready?
Mm-hmm.
Okay. Gradually increase the rate. A little faster. Okay. That's a normal finding. And then I want you to take your thumb and touch each finger on one hand, and then do the same on the next. She was able to do that. And then I want you to touch my finger with your index finger as I move. Okay. And now I want you to touch your own nose with your index finger. Okay. And now I want you to touch your own nose and my finger. Okay. And now I want to do the heel to shin test. I need you to lay back for me. And I want you to actually put your heel on your shin and slide it down for me. And do the same with the opposite leg. Okay, there was no problem there. You can sit back up. And the pronator drift is I want you to actually put your arms up and just up like this. And I want to make sure that you can keep them straight. And if they were to actually, come in, then that would be abnormal, and it would be pronator drift. And that concludes coordination and fine motor. Now we're going to do the cerebellar functioning, and I'm going to test my patient's balance. As you can see, we have a walkway, so she's actually able to walk. And first I'm going to assess her balance by doing the Romberg test. And I'd like you to, with your eyes open and then again closed after you do it open, I want you to stand with your feet together. You can kind of stand back. Stand with your feet together, okay? And I'm going to stay close to my patient just in case they have bad balance. I don't want them to fall. I want to be able to pick them up before they hit the ground. Slight swaying is normal as she's standing there, but a loss of balance or a lot of swaying could indicate a positive Romberg sign, and that can tell you that there is cerebellar ataxia, vestibular dysfunction, or sensory loss. And do it now with your eyes closed. Okay? So this is a negative Romberg sign. Now we're going to assess gait, hand, and leg coordination, or ataxia. I want you to take your shoes off. Okay? And I need you to walk for me just as you regularly would. And I should note that the gait, it should be smooth with a regular rhythm and a symmetric stride length. And she doesn't have any difficulty there. Arms should swing smooth and symmetric. And now we're going to do the heel to toe walking. And I want you to touch the toe of one foot to the heel of the other and walk with one foot in front of the other. Eyes open and arms at side. And she's walking in a perfectly straight line, no problems. And then backward the same. Perfect, perfect. Consistent contact should occur. Slight swaying is expected, but you should note shuffling, widely paced feet, and foot flopping and staggering, as that would indicate that there could be a problem. I want you to stand on one foot, okay, and do it again on the other foot. Walk on your toes for me. Okay, and now come back and walk on your heels. Okay. Now we're moving along to the reflex portion of the assessment. And first I'm going to assess the biceps. I'm going to have the patient flex their arm at 45 degrees. And I'm going to hold the bottom of the elbow and place my thumb over the antecubital fossa and actually strike my thumb. Okay. I'm going to assess the triceps. I'm going to have the patient flex their arm at 90 degrees, supporting the arm proximal to the antecubital fossa, and I'm going to take my reflex hammer and just above the elbow, I'm going to strike. Okay. And now I'm going to assess the brachioradial reflex. So I'm going to use the flat portion of my reflex hammer, and I'm going to hold the arm, and I'm actually going to strike. Okay, and the hand should actually move. Now I'm going to do the abdominal reflexes, and with the patient supine, if you could lay down flat for me, I'm going to stroke each quadrant of the abdomen with the end of the hammer, and upper abdominal reflexes will be shown by stroking upward and away from the umbilicus. Okay. Now we're moving along to the patellar reflex, and I'm going to have the patient flex their knee at a 90-degree angle, and I'm going to support the upper knee with the upper leg with a hand, and I'm going to let the lower aspect hang loosely, and I'm going to strike just below the patellar region. Okay. And now I'm going to do the Achilles reflex. I'm going to have the patient sitting upright, flex their knee at 90 degrees. And I'm going to actually hold this portion of their leg, and striking the Achilles tendon should elicit a response. Okay. Now I'm moving on to the Babinski sign, or the plantar reflex, and how I'm going to assess that is I'm going to stroke the lateral side of the patient's foot from the heel all the way up to the ball of the toes, and the patient should have flexion without fanning of the toes, so the toe should actually curl in. And I would do that on the other side as well. That concludes the reflex section. Now I'm going to move along to the musculoskeletal assessment, and I'm going to start with a focused assessment starting with the temporomandibular joint. And I'm going to put my fingertips on the anterior portion to the tragus, of each ear. And I'm going to gently palpate that region as the patient opens and closes the mouth. Okay. Open and close. And now move your jaw laterally, like to the side and side. And you should note that laterally the jaw should move 1 to 2 centimeters to each side. I want you to protrude your chin out and just bring it back into regular alignment. And now I want you to clench your teeth. Now we're going to move along to the cervical spine, and I'm going to assess the curvature of the spine, and I want to make sure that the head is erect to the body and in appropriate alignment. Could you stand up for me? And I'm noting that the head is erect and in appropriate alignment with the cervical spine. You can sit back down. And now I want you to do some range of motion exercises with me. And the first thing I want you to do is take your chin and put it on your chest. And that indicates flexion. 45 degrees is normal. Now I want you to take your chin and move it upwards towards the ceiling. Okay, and 45 degrees is normal for that as well. Now I want you to take each ear and put it to each shoulder one at a time. Okay. 40 degrees is normal for that. And now I want you to demonstrate rotation, and I want you to take your chin and move it towards your shoulder on each side. And 70 degrees is normal for that. And to do range of motion strength assessment, I would actually have her do all of the range of motion, flexion, hyperextension, lateral bending, and rotation of the chin again, but I would apply opposing force to the opposite side. Next, I'm going to assess the thoracic and lumbar portion of the spine. I'm going to look for the alignment, if you'll turn to the side for me, of the actual spine itself, noting symmetry. And next, I'm going to look for my landmarks, which is my C7, okay, and my T1. And I noticed the curvature of the spine. The thoracic portion of the spine should be convex, and the lumbar portion should be concave slightly. Noting any abnormalities in curvature, such as lordosis, kyphosis, and scoliosis, as we've mentioned earlier in previous videos. Paravertebral muscles are going to be assessed by having the patient standing erect. I'm going to palpate for tenderness. Okay. And no tenderness or spasms should be present. And then we're going to assess range of motion, and I'm going to have you, you can turn to the side, bend at your waist and touch your toes. And normal is 75 to 90 degrees. And now we're going to demonstrate hyperextension. I want you to bend back as far as possible, and normal should be 30 degrees. And now we're going to demonstrate lateral bending, and I want you to bend to side. Okay. Normal for that is 35 degrees. And next we're going to demonstrate rotation. We're going to swing the upper trunk to the side and then the back to the side as far as you can. And normal for that is 30 degrees. Now I'm going to assess my patient's shoulder. I'm going to inspect the symmetry and size and contour of all the shoulder structures. I want you to shrug your shoulders for me. To see if they're moving symmetrically, and your shoulders should move symmetrically. If there's asymmetrical movement or a contour, it could indicate dislocation. Now I want to palpate the clavicle. And what I would do on one side, I would do on the other. The scapula, the humerus, and the biceps groove and area muscles, and no tenderness should be noted on this assessment. Now I want to do shoulder range of motion. I'm going to have the patient shrug their shoulders once again, and the movement should be symmetrical. Now I want you to raise both arms forward and straight over your head, and that is forward flexion, and it should be 180 degrees. Now we want to do hyperextension, and I want you to extend and stretch both arms behind the back, and that should occur at 50 degrees. Now we want to do abduction, and I want you to lift both arms laterally and over your head, and that should occur at 180 degrees. Now we're going to adduct. We're going to swing each arm across the front of the body, and this should occur at 50 degrees. Very good. And now we're going to do internal rotation. I want you to place both arms behind the hips, and then I want you to stick your elbows out at 90 degrees. Okay? And now external rotation. I want you to put your arms behind your head and extend your elbows out at 90. Okay. And now I want you to shrug your shoulders while I apply opposing force. Okay. Now we're moving along to the musculoskeletal assessment of the elbow. First, I want to inspect the contour of the elbow as it's flexed and extended. And I want to note the carrying angle between the humerus when the radius is passively extended and the palms forward. Normal is 5 to 15 degrees laterally, and abnormal could indicate cubitus valgus, which is greater than 15 degrees. Medial deviation from the forearm would actually indicate cubitus varus, or varus. I'm going to palpate the elbow with it flexed at about 90 degrees. And I'm going to look at the extensor surface of the ulna, and I'm going to note the medial and lateral epicondyles of the humerus and the groove on each side for thickening of the synovial membrane, tenderness, and swelling. Now we're moving along to the assessment of the wrist and the hand. And first I'm going to inspect the dorsal and palmar surfaces of the hand for contour, position, symmetry, shape, and completeness of each digit. Okay. Now I'm going to look at the presence of the thenar eminence, which is the rounded mount on the thumb side of the hand. And then we're going to look at the hypothenar eminence, which is the less prominent on the little finger side, and I would do that on both sides as well. And then I'm going to palpate my interphalangeal joints using my thumb and pointer finger. And I would do this on the other side as well. And metacarpal phalangeal joints with both thumbs. And I would do that on the other side as well. Joint surfaces should be smooth without nodules, no swelling, no bogginess or tenderness noted. Abnormal would be like a ganglion cyst, which is a firm mass over the dorsum of the wrist. And I would also like to assess Tinel sign in the wrist, and I would tap it, and if there's tenderness noted, it would be indicative of carpal tunnel syndrome. Okay, now I'm going to assess range of motion of the wrist and hand. And I'm going to have the patient bend their fingers forward at the metacarpal phalangeal joint. Okay. And I'd like you to stretch your fingers up and back at the knuckles. And the flexion should be 90 degrees and the hyperextension should be 30 degrees. Now I'd like you to touch each fingertip to the base of your little finger. You can do it on the other hand as well. Okay, now make a fist. And back out, and all these movements should be possible. Now I want you to spread your fingers apart and then touch them together. Okay. And now I want you to bend your hand at the wrist, up and down. Okay. Flexion should be 90 degrees and hyperextension should be 70. And now with the palm side down, I want you to turn each hand to the right and the left. And this is radial motion and ulnar motion. Radial motion should be 20 degrees and ulnar motion should be 55. Now with the opposing force, we're going to do wrist flexion and hyperextension. So, and she was able to do that with ease. Now we're going to do muscle strength, and I need you to grab two fingers. Okay. Bilaterally, her muscles were strong. Okay, now we're going to move along to the assessment of the hips, and I'm going to inspect anteriorly and posteriorly while the patient's standing. And I would look at the symmetry of the iliac crest for height and the size of the buttocks, and also note the number of gluteal folds, if any are present. I want to palpate for tenderness, okay, noting any crepitus. And then we're going to move along to hip range of motion, and I'm going to ask you to lay supine. Okay. And I'm going to have you raise the leg with the knee extended above the body. And hip flexion should occur at 90 degrees. And then supine, I want you to raise one knee to the chest while the other leg is straight. Okay. And this should occur at 120 degrees. Now supine with one knee straight, swing the leg laterally and medially. Okay, and this should demonstrate abduction at 45 degrees and adduction at 30 degrees. And now, supine, I want you to flex the knee, keep one foot on the table, and rotate the leg with the flexed knee towards the other leg. Okay, and back out. And that's internal rotation at 40 degrees. Now, supine, I want you to take the lateral aspect of your foot out, and this is external rotation at 45 degrees. Now I'm going to apply resistance to the knee to be flexed and extended from abduction and abduction. So now, right, and now I can try to come out, right? And I would do the same on one side as I would on the other. Now we're going to look at the knee and inspect the knee and the popliteal space. Okay, and I want to look at the knee flexed and extended. And I want to note the landmarks, the tibial tuberosity, the medial and lateral tibial condyles, the medial and lateral epicondyles of the femur, and the patella bone. And I would do that on both sides. Lower leg alignment, normally the femur and tibial bone should be less than 15 degrees. Some abnormalities of the knee include genu valgum, which is knock knees, where your knees actually touch. I would also assess, standing up, for genu valgum, which is bow legs, and recurvatum, which is hyperextension of the knees with weight when bearing weight on the knees. Now I'm going to palpate the popliteal space, and I'm going to note any swelling or tenderness. The joint should be smooth without tenderness, swelling, bogginess, nodules, or crepitus. Now I'm going to have the patient demonstrate range of motion by having the patient bend each knee. You can sit back if you'd like. And flexion should occur at 90 degrees. And then I want you to straighten your legs out. And hyperextension should be up to 15 degrees. And now sitting and standing, but I'm going to just do it sitting. We're going to do opposing force to the knee with flexion and extension of the knee. And I would do that from one side to the next. Now I'm moving along to the ankle and foot assessment, and I want to inspect the ankles while my patient is bearing weight and while my patient is also sitting. I would want to identify the medial malleus and the lateral malleus, as well as the Achilles tendon, and I would also want to note my metatarsal phalangeal joints, which should be prominent. I want to look at the contour of the feet from the side, and also from the front, and note the contour. I want to look at the position of the feet, the size of the feet in relation to the body, and the number of toes present. Feet should be in alignment with the tibias. I also want to palpate the Achilles tendon and the anterior surface of the ankles, and with my thumb and fingers of both hands, I want to locate the metatarsal phalangeal joints. And I would do that on the other side as well. Now we're going to talk about some abnormalities of the ankle and feet. Pes vargus is the in-toeing of the feet. Pes valgus is the out-toeing of the feet. You can have hammer toe, which is the hyperextension of the metaphalangeal joint with flexion of the toes proximal joint. You can have claw toe, which is an overlapping of the toes. You can have hallux valgus, which is the lateral deviation of the great toe, which can cause overlapping of the actual second toe. And then bursa, which forms on your pressure points, and that's also known as a bunion. Now I'm moving along to the last portion, which is range of motion of the feet and ankles. I'd like you to sit back for me if you can. And I want you to point your foot towards the ground, and that's plantar flexion, which is at 45 degrees normally. And now I'd like you to move your foot towards the ceiling, and that is dorsiflexion, which is 20 degrees. And now I'd like you to bend your foot at the ankle and turn the sole of the foot inward and then outward. And inward is inversion at 30 degrees, and eversion is at 20 degrees. Now, rotating your ankle, I want you to turn the foot away from and then towards the other foot. Okay, and that's abduction at 10 degrees and adduction at 20 degrees. And now I want you to bend your toes and straighten your toes. And I expect to see flexion and extension of the toes. I want to try to get you to dorsal flex and plantar flex while I'm applying opposing force. And I noted her ankle strength was present. And this concludes my head to toe assessment, and I hope you've enjoyed watching it as much as I've enjoyed making it. Thank you.